Okay. So, welcome. I'm Dr. Charles Gervais, and this will be the very beginning of our Tom Godwin lectureship this year. So I'm one of the neurologists with the local Surrey Neurology group, working mainly out of Jim Pattison Outpatient and Surrey Memorial Hospital. It is a strange new world we live in, that once again I find myself in an essentially empty classroom talking to many people across a Zoom meeting. I can assure you that we're all wearing pants, because I know that is a concern at times for Zoom meetings. I'm going to first introduce Yolanda Bowman, who's been really instrumental in this lectureship series for the foundation. And she's going to say a few words and then hand it back, and then we'll get to introducing our speaker and go from there.
Unmute. Hello, everyone. Welcome very much to this Dr. Tom Godwin Neurology lecture. We're happy that so many people could join us from all over North America to learn more about headaches and migraines. My name is Yolanda Bowman. I'm a director of charitable giving and legacy gifts at Surrey Hospitals Foundation. Just wanted to mention that the lecture has been made possible by the Godwin family in honor of their husband and father, Dr. Tom Godwin, who passed away in 2013. Dr. Godwin was a cardiologist who was instrumental in starting and developing the cardiology services within Fraser Health Authority. He believed very much in the importance of collaboration and education among colleagues and medical disciplines, which is why the Godwin family have been so supportive of this annual lecture series. Your host for today's webinar has already introduced himself, Dr. Charles Gervais. We are so thankful that he is working with us behind the scenes to find wonderful speakers who specialize in different areas of neurology. Our organizing committee is very thankful to you, Dr. Gervais. And so without further ado, I will pass the reins back over to you. Thank you.
All right, so we'll move straight along. So I've had the great pleasure of being involved in this lectureship series for over 5 years now. We've had some excellent speakers over the years, including, national and internationally recognized experts in the areas of stroke, the areas of cognition, neuromuscular diseases, ALS, Parkinson's disease. But it occurred to me that, there was this topic we hadn't touched on yet that is very near and dear to all of our hearts as neurologists, because there's simply no escaping that headache continues to be one of the most pervasive things that any of us see in our practice. So I'm very grateful that I have the opportunity to introduce Dr. Juliana VanderPluym. Dr. Juliana VanderPluym is a Canadian speaker, did her pediatric neurology training with the University of Alberta. And after she was done, proceeded to go down and complete a headache fellowship with the Mayo Clinic in Arizona. And a very good reason for doing so is that Dr. Dodick, who's one of the preeminent experts on migraine internationally, is the head of the program down there. And she had the opportunity to work with him. And when it was over, they liked her so much, they begged to keep her, and she ended up working down there. So I'm very pleased to have her up as somebody who is a very up-to-date expert in the area of headache, particularly migraine. She had a recent major publication and several of them in high-impact journals, and she's spoken at many meetings, big and small. So without further ado, I will hand it over to Juliana VanderPluym.
Thank you very much for that kind introduction, and thank you so much for the opportunity to speak today. Many thanks to Dr. Goodwin's family for this opportunity as well. So today I'm excited to talk to you about acute treatment of migraine. And migraine is an area where there have been some huge leaps and bounds as far as treatments go, and so that's why this is a great topic. Okay, let's make sure my slides move. Okay, these are my disclosures. The grant from Amgen is in regards to research that does not pertain directly to this topic. And I've tried my best to highlight treatments that are available in Canada, as well as I will, if any treatments are off-label, I will identify that. So over the next hour, I'm hoping to define the goals of acute treatment of migraine, review best evidence for acute treatments, as well as the new acute treatments that are available, and finally also review some clinical scenarios for optimizing acute treatment of migraine. Now, I think it's important to remember that not every patient with migraine requires preventative treatment, but every patient with migraine warrants having acute treatment. So if you see a patient with migraine and they do not have anything that they are taking for their attacks, then you need to make sure when they leave your office that you have a strategy for them to use to address those attacks. Now, when we think about people who have migraine, unfortunately, there is a huge mismatch between the need and the outcome. And this study, the AMP study, found that of patients who had episodic migraine, so meaning that they have 14 or less headache days per month, only 45.5% of patients had a consult for migraine. Only 39.5% of patients received a diagnosis of migraine, and then only 26.3% of patients actually got appropriate treatment. So a quarter of patients actually got through all of those different steps and finally got a treatment. Now, if we look at this in the chronic migraine world, it's only about 5% of patients that go through all of those different steps. Now, why is acute treatment important? Well, in the short term, it's important because you need to provide relief for serious and debilitating symptoms. But in the long term, we find that inadequate acute treatment actually can be associated with an increased risk of new onset chronic migraine. So if you're not treating migraines acutely, you could actually potentially lead to them having a higher burden of migraines down the road. Now, when we survey patients as to their goals, what they want from acute treatment, what we find is that patients ideally want to have pain freedom. So not just that the pain is partially relieved, but that the pain is gone and that it does not recur, that they're able to function. So not that they take a medicine and they have to go to sleep, but rather that they take a medicine or use a treatment and they can go on with their day, that they don't need to repeat these treatments, that they're able to do it on their own. So they're not having to rely on the urgent care or the emergency department, that there is ideally minimal or no adverse events, and finally, that they can actually access these treatments and that they're not too costly. So when we think about designing a treatment plan for migraine, this really needs to be tailored to the individual. And there are three components to it. There is the education and expectation aspect. There is mitigation of lifestyle factors. And then there's either pharmacologic and non-pharmacologic treatments. Now, when we think about expectations and education, there was this paper that looked at what are patient versus medical provider goals. This is actually a very old paper. It's from 1979. And I think if someone redid this paper, they'd probably get it published pretty easily. But what they found was that for patients, their priority among 77% was actually having an explanation for their symptoms, followed by having pain relief. But for providers, their priority was pain relief. And so sometimes we have this mismatch where patients say, I feel like you're just throwing drugs at me. I don't really understand why. And this paper sort of showed that disconnect there. And that's why education and expectations are an important part of treatment. Patients need to understand what is their diagnosis. They need to know that they have a diagnosis of migraine and how we reach that diagnosis of migraine. And it's important for them to understand that there's no test that's going to confirm migraine. This is a clinical diagnosis based on your history and your physical exam. And then they need to understand that, the treatment options that we have available are not a cure. We do not have cures for migraine, but we have a lot of very good evidence-based treatments that are designed based on the mechanisms behind migraine. And so I have patients often that, I'll make my recommendations and then they'll say, you know what, no, thank you. I don't want a Band-Aid. And often I'll, explain to them that if I was treating you for asthma and I gave you an inhaler, you probably wouldn't tell me that you don't want an inhaler because that's a Band-Aid for your asthma. But for some reason, we think of treatments for pain conditions and treatments for migraine or headache conditions as these Band-Aids, when really they're actually appropriate evidence-based treatments based on the pathophysiological mechanisms. And that's why I'm recommending it. The other thing is that we have lots of options for treatment, but we don't have unlimited options. And so, at some point we do have to decide on a treatment, weighing the pros and cons of each of them. Now, I feel like choosing a treatment is sort of like putting together a puzzle. We're weighing the efficacy piece, we're looking at the side effect piece, we're also having to gauge access, and then we want to put that into the context of the patient and their comorbidities. Other barriers to establishing a treatment plan include comorbidities. Headaches and migraine do not exist in isolation, and some comorbidities can be associated as poor prognostic factors. So depression is one of them. And again, I really emphasize with patients that I'm not saying that their migraines are due to depression, but rather that having comorbid depression means that often their symptoms will be more severe, they will have more frequent symptoms, and often they will be less responsive to treatment. So we do want to treat depression concurrently with treating their migraines. Medication overuse is a poor prognostic factor, and I'm going to talk about that more in a little bit. Also, low headache management self-efficacy. So if patients don't feel confident doing on their own, often they don't do as well. Also, the presence of allodynia, and then finally, sleep and stress. So again, it's important to really think of the patient as a whole when we are addressing their migraines. Okay, so when it comes to the acute treatment of migraine, it really is location, location, location. A patient can have a migraine attack anywhere, and they can have any degree of migraine attack from mild to moderate, which can probably be managed in the outpatient setting, all the way to completely incapacitating, which probably may need to be managed in the urgent care emergency department or even in the inpatient setting. Now, in the setting of COVID, we really have been relying more on the outpatient setting because we have not had access to the emergency department, infusion centers, or inpatient care as much as we had in the past. And so we've had to get creative in how we manage patients, especially when they're having severe and incapacitating migraine attacks. When we're formulating our acute treatment plan, I always think about three main factors. One is the individual patient characteristics. So how old is the patient? What treatments are FDA approved for that group of patients? What is their medical history? Are they pregnant or planning pregnancy? Are they on other medications or other devices that may interact with what I'm choosing? Then we need to think about the migraine features itself. So what time of day does the migraine occur? How intense is it, especially at onset? Is it coming on, boom, super fast, or is it a more gradual onset? We also want to know if there's nausea and vomiting present and at what stage in the migraine, as well as the presence of allodynia, which is basically when non-painful stimuli become painful. And that is usually a sign of what we call central sensitization, meaning that the migraine has transitioned into sort of a more refractory state, and that's a poor prognostic factor when present. Then we really need to inquire about other therapeutic trials that the patient has had. So what did they take? How did it go? What side effects did they have? Because that'll help us decide what we can do next. Okay, now there are a number of guidelines out there regarding acute treatment of migraine. The Canadian Headache Society released one in 2013, so that one's getting a little bit old now. A few years later, the American Headache Society released another guideline. That one is a bit outdated as well because we have a lot of new treatments that have come out since then. There was an acute treatment recommendation paper regarding emergency department treatment. And then most recently, the American Academy of Neurology and the American Headache Society co-released a pediatric acute treatment of migraine paper. And then just last year, the American Headache Society provided an update that included some of the newer treatments I'm going to discuss. So this is a paper that I published recently. It's a systematic review and meta-analysis looking at the acute treatment for episodic migraine in adults. The bottom line of this paper is that there are a lot of different treatment options that are available, and they have mixed evidence. Some of the most kind of older and tried and true ones do have some of the best evidence, like NSAIDs and acetaminophen. And then we have newer treatments like the CGRP small molecule receptor antagonists and the serotonin 1F receptor agonists, which I'm going to talk about. And then, of course, there are triptans, which I'm going to spend a lot of the talk on as well. But bottom line, we have a lot of options. We just need to be smart about how we pick and choose them for the individual patient. Okay, so starting with acute treatment of migraine, self-care. So things that the patient can do on their own. Well, when we think about all of the older options for acute treatment of migraine, I like to break it down a few ways. We have sort of this idea of what would be the go-to to take for a migraine that's maybe not severe, so kind of your primary acute treatment. Then we have kind of the more moderate to severe migraines, your secondary acute treatment, and then we have the rescue. So these are the bad attacks. They haven't responded to your initial therapies. You're probably incapacitated from these attacks. And then we need to think about the side effects. So something like acetaminophen actually has pretty good evidence. However, by the time a patient is seeing you for migraine, they've probably already tried this. So unlikely that's going to be your first recommendation. NSAIDs can be very effective as well, but there's a good chance that the patient has already been on that also. And we do use these commonly for rescue therapy. So in the urgent care and the emergency department, you will see things like Toradol used frequently. The problem with NSAIDs, though, is that with long-term use, we do have to be mindful about cardiovascular risk, as well as renal disease, and then, of course, GI toxicity. Combination analgesics, so things that contain caffeine often, these have good evidence, but we don't really like using these because of risk of medication overuse. Triptans can sort of be used across the board. Ergotamines can technically be used across the board, but they're hard to access and do have a much more significant side effect profile. Muscle relaxers, they don't have great evidence, but we do use them sometimes as rescue therapies. Dopamine antagonists, so the neuroleptic anti-nausea medicines, these we will use. They have good evidence, but they're limited by their side effect profile often. Steroids, we reserve these as rescue treatments, and they generally are used in the setting of headaches with recurrence. And then opioids and barbiturates do not have good evidence. And so we recommend against their use also because they have a number of associated side effects. So triptans. There are 7 different triptans available, and sometimes it can seem a bit overwhelming how to pick and choose amongst these. So I'm going to break it down into a few big clinical categories. The first one are kind of the fast-acting potent triptans. So sumatriptan nasal spray and injectable, rizatriptan oral, and elatriptan oral are all pretty fast-acting and potent triptans. Now, amongst these, the sumatriptan injectable is going to get into the system the fastest. And so that one would probably be, the top pick if you have a patient who is really having a very rapid onset or has much more significant migraine attacks that they need a medication in their system quickly. The next category is those that have a long half-life, so the long-acting triptans. So that includes naratriptan, elatriptan, and frovatriptan. Now, frovatriptan is the major outlier here with a half-life of 25 hours. Elatriptan has a half-life of about 5.5 hours, but with its active metabolite, that half-life actually goes up to about 13 hours. And then naratriptan has a half-life of about 5 to 6 hours long. So these ones kind of come on slower, but they last longer. And then tolerability. Naratriptan, almotriptan, and frovatriptan have all good tolerability. In comparative studies, it appears that almotriptan actually has the best tolerability amongst the triptans. So triptans are commonly used, but a lot of the time people don't feel comfortable in prescribing them. And there's a few things to remember about triptans. The first is that lack of effect or the presence of side effects to one triptan does not necessarily mean that the same will occur with another triptan. And so sometimes patients will say, well, I've already tried sumatriptan and, it didn't work for me, so I don't want to try any other triptans. And that really is not the best approach because, sometimes they will respond to the other triptans, or they say, I didn't like how one made me feel, and so I don't want to try any of the other ones. But it really is good to try to encourage them to try at least 2 or 3 of the triptans. The other thing is that we always need to review with them some of the more unique side effects associated with triptans. And so flushing, patients will take a triptan and then they'll get this kind of whole body flushing feeling or warmth feeling. That will really be concerning if you don't sort of explain what that is. They might think they're having an allergic reaction. The other side effect is that people can get sort of this chest, jaw, or throat tightness. It's not an allergic reaction. It is not that they are having a heart attack. It's just sort of the vasoactive property of triptans. And again, if you don't provide sort of a warning that this is actually a common side effect, patients may misinterpret this as an allergic reaction, and then you're sort of throwing out a whole category of medications that can be very useful. Triptans should be avoided, though, in certain patient populations. So if patients have uncontrolled hypertension, if they have coronary artery disease, if they have had a stroke, and if they have had bowel or limb ischemia, then we would want to avoid triptans because of their vasoactive nature. The other thing is that a number of years back, the FDA put out a warning regarding serotonin syndrome if triptans were combined with SSRIs or SNRIs. That warning has not actually borne itself out in clinical practice. So there have been studies that have looked at hundreds of thousands of patients that are on that combination of therapy and have not found an increased risk of serotonin syndrome. So I definitely do let my patients know about this warning, because otherwise they might go and see a pharmacist, and then the pharmacist tells them about the warning, and then it sort of undermines the trust of our therapeutic relationship. But I do let them know that, unless they have had a history of serotonin syndrome in the past, this is not something that I am worried about for them specifically. So you make some of these recommendations, but how do you know that the acute treatment is working? Well, there's something called the Migraine Treatment Optimization Questionnaire. It's a 4-point questionnaire that can be helpful to actually gauge if these treatments are efficacious or not. And it's basically inquiring about whether they have pain freedom, whether it keeps the migraines away for at least 24 hours. Are they comfortable enough to kind of continue with their daily activities, as well as whether they feel it interrupts with their daily activities. And then based on that 4-question questionnaire, you can kind of add up the points and decide to what degree the medications or treatments are efficacious for them and whether you need to make any adjustments. So what are some of the most common clinical scenarios? Well, the first one is the patient comes back and says, my triptan doesn't work. The first thing I do before writing them a prescription for something else is I check at what point in the migraine they took their triptan. It's not uncommon that patients might sort of wait it out, and they'll kind of gauge, okay, well, is this my headache or is this my migraine? And then 6 hours have passed, they take their triptan, it does nothing. So it is really important to encourage them to take their triptan as early as possible. The other thing is to ensure that they are taking it at a full dose. I have a number of patients that will, take their triptan pill or their other pills and break them apart because they're concerned that they're going to run out. And so then they're just taking a partial dose and having not as much benefit from it. The other thing is that triptans can be repeated. So generally, you can repeat a triptan in 2 hours, except for naratriptan, which is repeated 4 hours later. So if they have done all of those things correctly for their migraine and it's still not working for them, then I will ideally try another triptan. However, if we've already tried a number of different triptans, then I'll switch to a different medication class. So another clinical scenario is that the patient is reporting having side effects. Well, one easy fix would be switching to those more tolerable triptans that I talked about. the almatriptan, the naratriptan, or the frovatriptan. Also, you could consider lowering the dose of the medication. The other thing would be ensuring that this is a true side effect and not an incompletely treated migraine attack. Sometimes I will have patients that will say, you know, I took my triptan and then I threw up. And then when you kind of go through the actual migraine attack, it might be the situation that they may have waited too long to take their triptan or took a partial dose. And it was actually just that they were probably going to throw up anyways, because it was just so far into such a bad migraine. But it now seems, just because of timing, that it was the triptan that made them throw up. The other thing is that sometimes you will have a partial response to treatment and the headache might go away, but they might still have all of their sort of migraine associated symptoms or a migraine prodrome that follows, where they feel just kind of tired and sort of weak and things like that. And then again, that gets misattributed as a side effect of the treatment, when actually it's just an incompletely or partially treated migraine attack. But if they do encounter true side effects and these adjustments don't help, then I will try switching to a different medication. Another option is that they may have headaches on awakening. So this is something that obviously, you know, often perks our ears to make sure that this is not a secondary headache disorder. So we do want to make sure when someone's reporting headaches on awakening that we've done a thorough history and physical exam to look for any signs of increased intracranial pressure, sleep disorders, or potentially medication withdrawals that might be contributing to that headache. But if we have ruled that out, then a few things to consider. One would be using a non-oral therapy. We always talk about treating migraine attacks early. And if you wake up with a migraine attack, then we're likely playing catch up, because we don't know if the migraine started the moment you opened your eyes, or if the migraine started 2, 3, 6 hours before when you closed your eyes and went to bed. And so we want something that gets into the system quickly, which is usually going to be the non-oral therapies. So the injectables, the nasal sprays, and we want a fast-acting therapy. Also, at this point in time, it may be helpful to combine with an NSAID, because if we're treating a migraine late into the attack, then that's often when we've sort of transitioned into the central sensitization phase, which can be more responsive to NSAIDs. The other would be that they're having recurrence after they've treated. So here again, we want to make sure that they are using their full dose, that they have repeated their dose. We could add an NSAID. Usually I would prefer a long-acting NSAID. And we could also try switching to a long half-life triptan, or try a different treatment like DHE, which can also be helpful when we believe that the migraine has transitioned into its more central sensitization mechanism. If nausea and vomiting is present, obviously we want to provide an anti-nausea medicine. That sounds sometimes a little bit silly, but we do sometimes forget that this is an option that we can provide to our patients. We also want to use a non-oral route, depending on how severe and at what time the nausea and vomiting occurs in the migraine attack. If the nausea and vomiting occurs hours into the attack, usually patients can take their oral medicines without issue. But if the migraine attack starts with vomiting, then often at that point, you would want to use an alternative route of administration. So suppositories can be helpful, subcutaneous or IM injections. Nasal sprays are kind of a bit of a mixed bag when it comes to nausea and vomiting, because if you incorrectly administer the nasal spray and it just goes down the back of your throat, that can make people want to throw up. Also, some of the nasal sprays, particularly sumatriptan, has not a great taste to it compared to zolmitriptan, which is a little bit better tolerated from a taste standpoint. So the nasal spray is nice in that it can be absorbed by the nasal mucosa, but if it's not administered properly, meaning that the patient just cocks their head back and shoots it basically down the back of their throat, then it might just compound the problem. Now, treating nausea and vomiting is important. There was a study that showed that patients with migraine who have frequent nausea that had persisted for 2 years of the study were twice as likely to progress to chronic migraine as compared to those with no or low frequency nausea. So again, this is sort of that same vein of, that same theme I talked about before, that us inadequately treating, acutely can actually have effects in the longer term for patients. Another clinical scenario is that the patient is just taking too much of their acute treatments. In this circumstance, it generally means that the patient is probably having very frequent migraines, so they probably need to have a preventive treatment. Also, this probably means that our acute treatments aren't working as well as we would like them to, so we probably want to switch to another category, and we do need to be counseling about medication overuse. Now, I think it's really important to not sort of play the blame game with patients, because it's not their fault that they're taking medicines. They just want to feel better, but they need to understand that sometimes these patterns of medication administration that we can get into can actually become part of the problem. And so there are some therapies that work both from an acute and a preventive standpoint that I'm going to talk about later. So just a little bit about medication overuse. Well, the concept is basically that, if you overuse medications, this could lead to rebound headaches. And this is something that we really see in the migraine population. So you may have cluster headache patients that are taking, triptans very frequently for their cluster headaches, and yet we don't see them getting rebound headaches or medication overuse headaches. So it is something unique about the migraine state that seems to be putting patients at risk for this secondary headache disorder. There is also a dose-response relationship, and that's based on the frequency of days of use. So we feel that around 10 days per month, or approximately 2 to 3 days per week of taking rescue medications is sort of the threshold for risk. Now, the risk for medications is not equal across the different categories. Opioids and barbiturates have the highest risk for medication overuse headache, followed by triptans, ergots, and then ditans, which are a newer group of therapies that I'll talk about. NSAIDs and acetaminophen, that's an area that people debate about, because it seems in some studies that NSAIDs might actually have preventive effect. And then GPANs, which are a newer category of therapies that I'll talk about, may actually have some preventive effects. So they seem to probably be at the lower, if at no risk for medication overuse. Now, how do we address medication overuse? Well, the best treatment is actually prevention for medication overuse. So educating patients on this so that they don't get into a pattern of overusing their medicines. We want to counsel on the risk. We would want to change out their acute medication. So if they're taking too many triptans, then maybe try them on an NSAID or something else. And then we would probably want to consider preventive therapies. The bottom line, though, is there is not any guideline recommended treatments for medication overuse. There is a study that probably in the next year will be releasing its data that was looking at how to treat medication overuse. And so hopefully in the coming year, we will have better data to guide recommendations for that. So what is the new acute treatments that are available? And when do you consider these? Well, if a patient has had contraindications, has had poor tolerance, or has had an inadequate response to at least 2 oral triptans, in the US, most insurance providers will allow us to move on to these new categories of treatments. So that includes the selective serotonin receptor agonists. So that's the ditan, lasmiditan. Then there are the small molecule CGRP receptor antagonists. So that's ubrogepant and rimegepant. And then there are the neuromodulatory devices. Now, the neuromodulatory devices actually do not require any insurance authorization in the US, but that also means that patients are paying for them out of pocket. Now, all of these therapies do not constrict blood vessels, and so they can play a role in patients with vascular contraindications to triptans. Now, I starred the ones that are currently not available in Canada. So lasmiditan, ubrogepant, and rimegepant, transcranial magnetic stimulation, and then conditioned pain modulation. Those treatments, as far as I could tell, and in discussion with the companies that make these, are not currently available in Canada. So selective serotonin receptor agonist. The first and the only one available in this class is lasmiditan. This was FDA approved in October of 2019. And this is a serotonin receptor agonist. And so you would say, oh, okay, well, triptans are serotonin receptor agonists, but it's to the 1F receptor, while triptans block the 1B or 1D, or I should say bind to the 1B or 1D receptor. So different receptor binding properties, and that results in different side effect profile. So because lasmiditan does not bind to the 1B receptor, it does not have that vasoactive property. And that's what makes it a very good choice for patients who have vascular conditions that would prevent them from using triptans. However, there are some nuances to use of lasmiditan. Lasmiditan is a centrally acting medication. The serotonin 1F receptors are densely populated within the central nervous system. And as a result, the most common side effects are dizziness and somnolence. And so that's a major downside for this treatment, because if you already have someone who is feeling horrible from a migraine, and then you give them a treatment and say, this is going to make you dizzy and somnolent, that might not go over very well. Additionally, it is currently classified as a substance level 5 in the US. So it's a controlled substance, and it has driving restrictions. So patients cannot drive for 8 hours after taking lasmiditan. So how would I use this medication? Because I've just said some things that are not so positive about it. Well, I use it in my rescue category. So this probably isn't going to be a first line or a second line therapy for most patients, unless they really have no other options. It would probably be an ideal medicine for patients who have attacks later in the day. So they're maybe planning on going to bed anyways, or for patients that their lifestyle, wouldn't be affected by them not being able to drive. So, if someone doesn't have necessarily something that they need to leave the house for, like a job outside of their home, then maybe this would be an option that would be more suitable for them. It is recommended that you start at the lowest available dose, which is 50 milligrams, and then you can subsequently increase the dose. You can only take one dose for 24 hours. And it does seem that if you start lower, that will be better tolerated. However, the higher doses appear to have better efficacy. Now, we still don't have good safety data as far as combining this with triptans, because they are going to both be serotonin receptor agonists. And so the question is, if you're combining these different receptors, what would that look like from a safety standpoint? And we don't have that data just yet. So the other category of new medications are the CGRP small molecule receptor antagonists, or the GPANs. Ubrogepant came out in December of 2019, and it comes as a 50 or 100 milligram pill. This is more like how we're used to dosing triptan. So you can take a second dose 2 hours later. You do have to be mindful, though, of renal and hepatic dose adjustments for this medication. Rimegepant, that one came out in February of 2020 for acute treatment of migraine. And then it was subsequently FDA approved for preventive treatment of episodic migraine in May of 2021. So that one is more recent as far as its availability. That one is a 75 milligram pill, and it's a long-acting medication. So you just take one pill per 24-hour period. If you are prescribing it for preventive treatment, you actually would take it every other day. So with the GPANs, these lack vasoconstrictor activity. So they would be preferable to triptans for patients who have vascular contraindications. However, they are not necessarily as safe from a vascular standpoint as we consider lasmiditan. And the reason behind that is that lasmiditan and the GPANs, neither of them are vasoactive. They don't cause any vasospasm like triptans can, but the GPANs block CGRP, and CGRP is a compensatory vasodilator. So theoretically, if the body needed to undergo compensatory vasodilation and you were blocking CGRP, there is the theoretical risk that this could have a negative outcome in a vascular event. So it's not that it would cause a heart attack or it would cause a stroke, but let's say one of those things was happening and this medication was in your system, then maybe the outcome of that event would be different because of this medication. However, that's a theoretical risk. It has not borne itself out, but it's a consideration with regards to these medications. Now, the common side effects with the GPANs are fatigue and nausea. Both were reported about a 3% rate in the trials. These medications do have some interaction issues with a CYP3A4 inhibitors and inducers. And so if patients are on certain antifungals, antibiotics, and calcium channel blockers, or barbiturates, then the medication dosing does need to be adjusted. Well, the bottom line is, are these newer treatments better than triptans, better than what we have available? And the bottom line is that when we look at primary outcomes for odds ratios for pain freedom at 2 hours, most triptans actually do better. So these new medicines from a pain freedom outcome don't necessarily outperform what we have available as far as triptans. Secondary outcomes like pain relief, most triptans do better from that standpoint as well. Lasmiditan was actually associated with higher risk of adverse events compared to triptans, but it appears that rimegepant and ubrogepant had lower risk of side effects compared to triptans. So people would say, well, what's the point then? I mean, these new medicines aren't even available in Canada. They're probably more expensive, which they are. But I think it's important to remember that we have lots of patients that triptans just don't work for them, or that triptans are contraindicated for them. And so it really is important for us to be able to expand our arsenal of available treatment options, even though they may be just sort of comparable as far as their outcomes. Now, one of the newer groups of treatments are the non-pharmacologic, non-invasive neuromodulatory devices. And some of these are available in Canada. So that's the non-invasive vagus nerve stimulation, as well as the supraorbital nerve stimulation. The ones that are not available in Canada as of yet are the transcranial magnetic stimulation device and the remote conditioned pain modulation device. What's interesting about these devices is that, first of all, they're not a medication. So that's nice for patients that are concerned about side effect profile. They unfortunately are usually an out-of-pocket cost. In the US, they are not covered by most insurers. And so they can range in cost from about $400 to purchase the device to potentially having to lease the devices on a monthly basis at around $250 per month. But what is the most unique thing about these is that they sort of are on the fence between being an acute and a preventive treatment. So they can work for both potentially, depending on which setting you have them in. And we also don't worry about medication overuse with these. So patients can use them as much as they need to, and we're not worried that they're going to get withdrawal effects from them or negative side effects as far as rebound headache. So this is just a summary to sort of show you comparisons between what we have, like NSAIDs, combination analgesics, triptans, ergots, compared to the newer treatments like GPANs, ditans, and the neuromodulation devices. And what this is pain freedom proportion in patients receiving active treatment subtracted by proportion in patients receiving placebo. So how much more benefit was gained above the placebo response? And so we can see that in general, the newer therapies do not perform as well as what is currently available. But they're pretty comparable. So the lines do overlap between the groups. The older therapies, though, have their downsides as far as side effect profiles and the fact that many patients have tried these and not received benefit from them. And so that's why it is important to have this table continue to expand and extend itself out, even though we're not seeing these newer therapies, way up here somewhere, because that's not necessarily the point. I mean, obviously, it would be great to have therapies that work even better, but I think it's good to have therapies that work as well, with potentially less side effects and greater, the opportunity to use it in more patient populations that can't use the other therapies. So I've talked about a few treatments that sort of blur the lines between acute and preventive migraine treatment. So rimegepant, which I talked about, which is both FDA approved for acute and preventive treatment, depending on the dosing. Neuromodulation, which depending on how you administer it can be used for either. And then interestingly, eptinizumab, which is available in Canada, released a study that showed its utility in breaking a migraine when it was administered during a migraine attack. So eptinizumab is the only IV CGRP antibodies. So those are being used right now for preventive treatment of migraine. But what they found was that when a patient was in a migraine attack and received the eptinizumab infusion, they actually had a higher likelihood of acutely going into pain freedom, as well as absence of most bothersome symptom. So this is sort of an interesting medication where basically someone could be in a migraine attack, you administer this therapy, you've started them on a preventive treatment, which hopefully will now reduce their frequency and severity of migraines long-term, plus you might have had the benefit of breaking a migraine attack acutely. Side effects with this medication include hypersensitivity reaction, and it is administered every 3 months by IV. So that's sort of a downside as far as being able to access an infusion center or a hospital where you can receive this medication. So going beyond self-care, now the patient has tried their at-home therapies, it hasn't worked for them, what are they going to do next? So this is sort of the status migrainosis situation. Outpatient therapies that we do use include steroids, prescription anti-inflammatories and the dopamine antagonists, sumatriptan sub-Q if they haven't already taken a triptan at home, or sometimes we'll do a course of the long-acting triptans, DHE. And over the pandemic, we were getting creative and actually using short courses of preventive treatments like valproic acid or gabapentin over 3 to 5 days to try to break refractory migraine attacks. If the patient comes into the office, you can try IM ketorolac or IM dopamine antagonists, nerve blocks if you have training. And then if they're transitioning to the emergency department, then you're probably going down an IV route of using an IV NSAID combined with a neuroleptic anti-nausea medicine, and then kind of working your way through different tiers of therapy. So, there is still a gap in our evidence as far as what is the best, but that review that I talked about that sort of summarized the data for treatment in the emergency department has found that intravenous metoclopramide and prochlorperazine do seem to have some of the highest level of evidence. Dexamethasone should be offered to patients who to prevent recurrence of headache. And we do really want to avoid opioids because they do not have good evidence. So we have a lot of outstanding questions regarding acute treatments. We don't know completely the long-term and frequent use safety profile. A lot of the trials are designed based on treating 1 to 3 migraines. And if it turns out well, then that's, a positive outcome. So, how does this, how does this translate to the patient who's having 10 migraine attacks per month and taking these treatments 10 plus times per month for months on end, for years on end? Pregnancy risk is something that we are still exploring. Medication overuse risk as far as the newer treatments. Cardiovascular risk of the GPANs as far as I talked about the theoretical risk of blocking CGRP. And then combining GPANs with the CGRP blockers. So what is the effect of double blocking CGRP? We do need more comparative studies. A lot of the studies now are compared against placebo, which then makes it hard to try to compare, basically you're kind of comparing apples and oranges at that point in time, but not against one another. Status migrainosus is an area where we don't have great data as of yet. And of course, the holy grail is biomarkers. So being able to say, this is what we see on your saliva or your blood test, which means that this is the mechanism of action of your migraine, which means this is the treatment that you would respond to best. So in closing, I just wanted to cover a few special circumstances in migraine that come up. One of them is the pediatric patient. The recent guideline that was released found that the best evidence supports ibuprofen, acetaminophen, and then zolmitriptan and sumatriptan naproxen combination. There are, however, 4 triptans that are FDA approved for pediatric patients. And so that's zolmitriptan, sumatriptan naproxen combination, almotriptan, and rizatriptan. And rizatriptan is FDA approved down to 6 years of age. So it's the only one we have available for the youngest children, besides things like ibuprofen and acetaminophen. There are 2 neuromodulatory devices that have been FDA cleared for kids 12 years of age and older, and that is the non-invasive vagus nerve stimulator, as well as remote condition pain modulation, which is applied to the arm. The non-invasive vagus nerve stimulation is available in Canada. Now, acute treatment of migraine in pregnancy. This talk isn't dedicated to pregnancy, but it's something that comes up a lot because of the fact that patients with migraine are often females of childbearing age. My first tier recommendations are acetaminophen, metoclopramide, or diphenhydramine, depending on the severity of the migraine attack. NSAIDs really can only be used in the second trimester, so I generally avoid them because it is hard to sort of keep track of where someone is in their pregnancy, and if they kind of forget about that recommendation and then start continuing the triptans later, or sorry, the NSAIDs later into the pregnancy, that becomes problematic. Second line are triptans, and we are becoming more comfortable using triptans in pregnancy. The ones with the best evidence are sumatriptan, naratriptan, and rizatriptan. We always recommend using the lowest possible dose, and all of these treatment recommendations have to be with the OBGYN being on board. Non-medication based interventions like the neuromodulatory devices, so transcranial magnetic stimulation or the trigeminal nerve stimulator, can also both be considered. Now, if a patient is not responding to those treatments, then we do often prefer lidocaine-only nerve blocks. In lactation, very similar recommendations. The triptan choices change a little bit. We don't have great evidence for triptans with breastfeeding. Elatriptan has the lowest concentration in breast milk, and so that's often the one we will prefer to use. We also prefer to use lidocaine-only nerve blocks for our very refractory patients. The last thing I wanted to touch on is menstrually related migraine. So menstrually related migraine is basically when migraines occur more commonly around the menstrual cycle, and then pure menstrual migraine is when migraines occur only around the menstrual cycle. Now, about 1 in 3 women experience menstrual migraine at onset of their menarche, and 60 to 70% of women experience menstrual related attacks in general. These attacks, unfortunately, can be more painful, last longer, and can also be much harder to treat. But they're a unique opportunity to use what we call mini prophylaxis or mini bridges, where basically you will give a patient a rescue medicine that they will take for 5 days around the time of their menstrual cycle. And so what I mean by that is if they start their menstrual cycle here, so that would be day 1, you would want them to take the medicine starting 2 days before that, and then the day of the expected beginning of their menstrual cycle and migraine, and then for 2 days that follows. Now that can be shifted if they say, it starts on the 2nd day of my menstrual cycle or whatever. But the bottom line is that this requires that they have a regular menstrual cycle, because if it's irregular, then you can't predict when it's going to start, and then you can't give it to them 2 days before you expect it to start. The options for a mini prophylaxis include naproxen, but the best evidence is for frovatriptan, followed by naratriptan and zolmitriptan, which have level B evidence. So in conclusion, every person with migraine warrants having an acute treatment. There are many options to treat migraine attacks. Unfortunately, not all of these are currently available in Canada, but I'm telling you about them because this is an opportunity to advocate for your patients with Health Canada to try to get access for these treatments for your patients. Most people with migraine will have more than one type of attack. And so you want to strategize based on when the attack occurs, if it has nausea or vomiting, how quickly it comes on. And the lines between acute and preventive migraine treatment are blurring. And so the hope will be in the future that, as we are providing these acute and rescue medicines to our patients, we're not just treating their symptoms in that moment, but we're preventing potentially the next attacks that might be coming. Thank you very much. And I will open it up for any questions, which I think are in the chat.
Yeah, so I'll just pop back in here for a moment. And so just as I sent at the very beginning and just resent at the end, where we have some time dedicated for a question and answer section, and then we'll have a conclusion after that. Can I just confirm that you're able to see any questions that were directed to you? The directions were sent to copy them directly to you?
So there was one that was talking about whether this will be recorded, and I believe it is being recorded, but I will defer to you if that's true or not.
Yeah. So if anybody else has directed questions during the chat, essentially when you're in the chat, you would have to go to the drop-down menu as to who you're directing it to, and then you would type the question directly to Dr. Juliana VanderPluym's profile. If none have appeared yet, that may just be that none have popped up. I've had at least one come to me that I had forwarded, so I'll try and resend it. Yeah, so when you're able to pull up the chat, are you able to see anything just yet? I just sent another one.
Yeah, I'm seeing a few here.
Yeah. So just while you're looking at that, I just want to stress a couple things. We, even prior to the presentation, had some very good questions submitted. And just to stress that Dr. VanderPluym is a practicing physician in the US. So some of the questions that were already sent and some of the questions that are being submitted, we'll obviously do our best to answer from a general perspective, but we wouldn't be able to address very specific or personal kind of clinical scenarios. And so if any of them have popped up, we'll do our best to answer them generally. This is the first year that we've done this format. So if your question doesn't get addressed, I'm very sorry for that. We're doing our best from our end to make sure it'll appear there. And she obviously is now going to have to scan through a window showing a bunch of questions in sequence. So I know she'll do her best if they're appearing there. If not, we'll keep working on it.
Sure. So I'll start working through these. I think one of the main questions is, will this talk be available online? I will direct that to the team organizing, but I believe that since it's being recorded, I imagine it will. It also looks like someone's writing across, but I'm not sure who that is. Okay, so
yeah, you can ignore that. Please do not use the draw function on the screen. Thank you.
Okay, so a few questions here. Okay, so one question was, the idea that someone is using something like Tylenol with caffeine. They've been using it regularly for about 8 years now. They take it as soon as the migraine starts. The headache goes away, but still get them 2 to 3 times a week. So, this is a good example where you are seeing that benefit in the moment from a combination analgesic, which is what we do see. But the problem is that you're having a frequency of headaches that would probably warrant trying a preventive therapy. The other issue is that with combination analgesics, we do run the risk of medication overuse. And so, although you're getting that immediate benefit from it, this is probably an opportunity where you would want to reach out to your local provider because you're having somewhere between, anywhere between 8 to 12 migraines per month. And so maybe considering a preventive therapy might be a good option. The other thing would be, considering a triptan as well. Another question that came up There was a question about seeing iron and ferritin and vitamin D deficiency in my patients. Do you recommend checking this as a screen in patients, as studies do support that correcting this can improve frequency and severity of migraines? So I would say that as a standard practice in my pediatric patients, it sort of depends on the overall history. I do not necessarily check vitamin levels in all of my patients. However, if there's someone who is having very frequent headaches and migraines, and they're also reporting more general symptoms that could suggest something like an iron deficiency or vitamin D deficiency, then I will usually do a standard lab panel, including vitamins to check. The vitamins that have evidence for supplementation in migraine, and this isn't based on necessarily having a deficiency, but just as nutraceuticals, are magnesium and vitamin B2 that have the best evidence. But it is important, to always keep in mind when you're doing a headache assessment regarding if there could be any secondary contributing factors to headaches, because, we can see that nutritional and vitamin deficiencies obviously can, just as a secondary cause of headaches, contribute to headaches. Okay, I'm going to try. A question was, do migraines ever disappear? So that's a very good question, and one that comes up a lot. The bottom line is that migraines, I think, we need to sort of change our concept of migraines to migraine. Patients have migraine, which is a condition that is defined by having attacks of migraine. So the constitutional trait, or the disease, the neurologic disease of having migraine, is something that will never disappear because it's wired into your genes. But how the migraine attacks present themselves over your life can change. And so that's something that, people can have them in childhood, and then they can get better in their adult years. And then as they get older, they can come back, or vice versa. They can have them, in their adult years, and then they can go away later on in life. So having migraine will never disappear, but how your migraine attacks present themselves can change. Question, how do you treat menstrual migraine in young adolescents that is not responding well to NSAIDs? Do you move on to the mini prevention with the triptan? So if a patient, whether it's a young adolescent or whether it is an adult aged woman, I will use triptans if they have not responded to NSAIDs, and I will use that as a mini bridge. The other important thing with menstrual migraines is to always clarify if they have migraine with or without aura. Because menstrual migraines are hormonally related, they can respond well to preventive therapy with continuous oral contraceptive. However, you cannot use estrogen-containing contraceptives in women who have migraine with aura. So that's just the caveat there. But yes, I would usually consider using a mini prevention with a triptan in a patient who hasn't responded to NSAIDs. Sorry, there's lots of questions coming through, but just remember that I can't answer sort of personal questions because I am not licensed to practice in Canada, and also because I haven't clinically assessed you. So one question was, do you have recommendations for treatment or prevention of frequent migraine aura without headache? So migraine aura without headache is definitely an interesting condition. First of all, you always want to ensure that it is truly migraine aura without headache and not some other condition that's mimicking it. But if indeed it does fit best with migraine aura without headache, one option would be trying a nutraceutical like magnesium for prevention. Lamotrigine, which is a prescription medication, is also sometimes used for this indication as well. There has also been some data where people have looked at use of aspirin or even a clopidogrel for this. But the most important thing, obviously, is reviewing this with your physician and ensuring that this is the correct diagnosis. Yeah, another question was, have any research studies been done on using fitness to prevent headaches and migraines? So that is an excellent question. And yes, there actually has been research that have been done looking at exercise for migraine prevention. And what they found was that particularly in episodic migraine, so when patients are having 14 or less headache days per month, exercise does appear to provide benefit, and it can be used as an excellent preventive agent. Unfortunately, that benefit did not seem to bear out as much in chronic migraine, not because exercise isn't as important, but just because it didn't have the same positive results in the trial, meaning that it didn't show kind of the same degree of change for patients. So exercise and optimization of lifestyle in general is very important in migraine. A question is, what is the efficacy of Botox for chronic migraine? So migraine or Botox is FDA approved only for chronic migraine. It's not FDA approved for episodic migraine. And this is something that has been used now for quite a while. In the studies, about 67% of patients noticed a 50% reduction after the first round, 50% reduction in frequency of headaches after the first round of Botox. And then another 10% of patients noticed this after the second and third round. So we do always recommend trying at least 3 rounds of Botox before someone's considered a non-responder, because sometimes it just takes a few rounds to notice full benefit. Sorry, trying to read through the questions. There was a question about whether to use sumatriptan for mini prophylaxis for menstrually related migraine. So there currently isn't any good data as far as using sumatriptan. The data has really been in regards to frovatriptan, naratriptan, and zolmitriptan. Just because of the half-lives of those medications, which are more conducive to sort of having something stay in your system for that kind of concentrated short duration of time. So, if you have a patient who uses sumatriptan for their migraines outside of their menstrual attacks and then has a prescription for one of those other triptans, that is something that I'll sometimes do where I'll say, you can take your sumatriptan for the other migraines, and then when you have your menstrually related migraine, we'll give you frovatriptan, naratriptan, or zolmitriptan to take for that 5-day window. You just want to make sure that they're not combining the triptans together. Now let me scroll down to the bottom because there's more questions that have shown up.
Just while you're doing that, heads up that we're getting to the 10 minutes after the end of the presentation mark. So when we get to the 10-minute mark, probably another few more minutes for final questions, but already grateful for the questions you've answered. So kind of about 5 to 7 minutes more.
Okay. Okay, so one question was something that I had talked about before, which is if someone is awoken by their migraines or headache, what to do at night. So in a circumstance like this, first and foremost, you want to make sure that there isn't some other condition that's causing them to have headaches, waking them from sleep. And once you've ensured that there are no other conditions causing them to have headaches, waking them from sleep, then you would want them to take a fast-acting medication and probably a non-oral route, and may combine it with an anti-inflammatory at that point in time. Let me see here. It keeps bringing me all the way up to the top of the question, so I sort of lose where I am in my question route. There was a question, this is more about preventive treatment, but curious about thoughts on beta blockers. So beta blockers are used very commonly for migraine prevention. Depending on the beta blocker, they do have level A evidence for migraine prevention, and some of them are FDA approved for migraine prevention. So I think that is an option that, in the US we use very frequently, and it's actually one of the steps that is required to try before we can escalate to some of the CGRP antibodies or to Botox. So they're very commonly used. What do you think about psychotherapy as an option for migraine treatment? So there is excellent evidence in both the pediatric and in the adult population for use of cognitive behavioral therapy, as well as biofeedback training for migraine treatment. So if you have the resources available and you have access to a psychologist who's trained in cognitive behavioral therapy or biofeedback training, I am all for it. There are some excellent resources online, including dawnbuse.com. She's a psychologist who specializes in migraine. There's also something called the Migraine Masterclass, which talks about that in more detail as well. One question, this is more general: how do you determine headache from migraine? So that's something that has to be done in association with a physician or medical provider, but there are diagnostic criteria. You have to have at least 5 attacks. The attacks last between 2 to 72 hours. You need to have at least 2 of 4 features, which is either that the headache is on one side, it's moderate to severe in intensity, it's throbbing or pulsing, and it's worse with activity, and at least 1 of sensitivity to light or sound or nausea and vomiting. So based on those criteria, and then a normal neurologic exam, and usually a family history, those things can be supportive to help diagnose migraine.
I'd like to sneak in a question. I'll pull rank if I could,
Sure.
Just because I know it's a challenging scenario you've encountered and that other neurologists and also many of our primary care practitioners or other allied physicians encounter, which is you've very well presented all the different classes of medications that are considered, but a scenario that comes up, a patient that you end up seeing in consultation has migraine, whether episodic, chronic, or both, but for one reason or another, either for the treatment of pain or headaches, is already on some form of chronic opioid therapy. And kind of outlining the concept of central sensitization. And we've already talked a bit on medication overuse headache in your talk, but it can be very challenging in that setting for physicians to kind of go over, well, this probably isn't the optimal thing. And my main question is, in tying to that and discussing with a patient how you're going to approach it, any evidence that you often cite when you have that difficult discussion to say, well, here's why we should move away from this and go more towards that, in that difficult scenario where many patients are often very reluctant because they identify some benefit to something that may actually be causing more harm in the long run.
Yeah, that's a really tricky situation because, especially in our patients with chronic migraine, we do find that as a common comorbidity, they have other pain conditions. And so it's not uncommon that we have a patient who is on pain medications for a number of different reasons. And so that's actually one part of the history that you always have to be mindful of, because you might say, oh, what are you taking for your headaches? And they'll say, oh, I take, Excedrin, let's say. And then you're like, okay. And then you're like, what other medicines are you on? And then they list that they're also on pregabalin and they're also on OxyContin and this and this and this for all these other pain conditions they have. So, my approach to it is that, first of all, you also want to gauge to what degree those medicines are helping their other conditions. It's not uncommon that they're actually not getting that much benefit for their other pain conditions, but now these are just medicines that they've accumulated. And so then it is sort of a matter of working with their pain specialist to see if there are other therapies that they could be considered for, whether it's procedural, medial branch blocks or injections or something that they could get that maybe could replace the opiates. Now, if opioids are really the only option for their other pain condition, because they shouldn't be the only option for their migraine, hopefully, then it's a situation where we just have to explain to the patient that this isn't an ideal circumstance in the sense that the opioids can be changing their pain processing. We know that, once the opioids bind to the receptors, more opioid receptors are going to develop. And so it's not just, that you're taking it for your back pain and it's just sticking in your back. I mean, it's everywhere in your body, and it's affecting your whole body as a, interconnected system. So from that point in time, I do really try to focus as much as possible on optimizing their preventive therapies, because there have been treatments, both actually with the onabotulinum toxin A trials and with the CGRP trials, where they have shown benefit for patients that are overusing medications. So, it is one of those things where I think it's really important at that point to try to optimize their preventive strategies as much as possible, because you can still get breakthrough relief, even despite those other therapies, those other treatments kind of being in the patient's system. The Migraine Masterclass is a really good resource that patients can access online. It really goes through kind of all of migraine treatment options, medication overuse, all these things that, can kind of provide context for what they're going through. Being in the US, I am affiliated with the American Headache Society and the American Migraine Foundation. Obviously, the internet has no boundaries. And so those are things that patients in Canada can access to and are very well vetted resources, because sometimes you go online and you find stuff that is biased, I guess is maybe the best way of putting it. So those are good resources as well.
Thank you very much for that. Again, I know a very difficult question, and as you coming back to the very beginning of your presentation, a tailored approach to every patient, right? And it's not an easy answer. No. I greatly appreciate all the questions that were submitted. I'm sorry to any that we didn't get to, but I'm grateful to Dr. VanderPluym for answering so many of those questions in detail on the fly, especially. I'm also grateful to everybody who attended. This is the first time we've done the Godwin lectureship in this format, so I hope it was enjoyable and efficient in kind of a unique circumstance. Obviously, we'd love to get back to a live forum at some point, but we can also refine this even better as we go. And then, of course, to bring up some final thank yous, Yolanda Bowman, Jazz, and a number of other people who are there in the background. Yolanda's been so instrumental in this. And then, of course, there's Elaine. I wanted to make sure we made a point of mentioning the Godwin family, and especially Elaine, are the reason why this lectureship exists. And it's a very unique lectureship, if you look across the country, that our neurology group has the opportunity to be involved in. It made possible originally thanks to the contributions of Dr. Godwin, Tom Godwin. He was a cardiologist, fantastic human, and so inspiring to so much of the development of healthcare, and not just in terms of the facilities and the clinical, but also in terms of the academics and the multidisciplinary support. And so his legacy lives on through this lectureship series. And Elaine, once again, thank you for another year of such great support to make this possible. And we'll keep working on getting great speakers like Dr. VanderPluym. So with that, I'll call it for there. Thank you again, and hopefully we see you all and even more next year.
Thank you so much for the opportunity. Bye, everyone.